Today's webinar is the application of Janda's concepts of neuromuscular assessment and treatment in the athletic population, and is presented by Andre Labbe. Just a little background on our presenter today. Andre Labbe joined Tulane University as an instructor for the School of Medicine, Department of Orthopedics in July of 2018. He is the Director of Rehabilitation and Return to Play for Tulane Athletics. He is the only physical therapist on staff for Tulane Athletics. He is also the Director of Outreach for Tulane Institute of Sports Medicine, where he's responsible for maintaining and developing sports medicine outreach throughout the greater New Orleans area and surrounding parishes. Andre graduated from PT schools in 1991 from Louisiana State University School of Medicine in New Orleans. He started his practice in Lake Charles, Louisiana, under the direction of Dr. David Dredz and Russ Payne, PT. Andre ran the outreach program for Lake Charles Memorial Hospital in the area of Southeast Texas. He was recruited by the Health South Incorporated in 1994 and directed the outpatient clinics in the greater New Orleans market. In 1995, Andre received his master's in orthopedic and manual physical therapy. He became the clinical leader for the Health South Corporation. He was asked to become part of the PGA Health System team in 1997 and traveled to numerous events in the United States, supplying manual therapy treatments to the players. In 1999, he began training with Vladimir Janda of the Czech Republic. There, he studied the concepts of muscle imbalance therapies and the application of development kinesiology in sports medicine. In 2012, Andre became part of the New Orleans Saints Athletic Training Department, where he helped with post-op rehab and return to play. 2015, he began working with Dr. Buddy Savoy on complicated elbow and shoulder surgeries and the best way to return players to full function. So we welcome Andre today. A little bit before Andre gets started, just about the Center for Sport at Tulane University. The Center for Sport is backed by Tulane University and relationships with local, national, and professional sports organizations. The Center for Sport has developed an interdisciplinary network of resources, knowledge, and experience all under one roof, and puts us in the unique position to view sport from a 360-degree perspective. Our work promotes cross-campus connections that allows us to examine crucial problems facing athletes, sport, and society, as well as develop careers and innovative answers to issues that affect the sports industry. Our mission is to educate current and future professionals in the area and to improve the emotional and physical lives of athletes by advancing cutting-edge sports research and health services, and to inspire social change by promoting the powerful impact of sport and the role of athletes in the community. At this time, I am going to hand over the webinar to Andre Labbe. Thank you for being here, Andre.
Thank you. Thanks for the intro, and thank you everyone for being here. I'm actually excited to be able to kind of delve into some of the stuff that we've been working on, that I've been working on for the last 15 to 20 years, and really kind of bring it full circle, and also kind of open up a little bit about what we're doing here at Tulane and how we've kind of integrated this into our practice here. So yes, I'm part of Tulane, very proud to be here, really thankful to a group of great physicians and a great athletic training program, both with the Institute of Medicine and with Tulane Athletics. It's kind of the eventual dream job I always wanted, and really it's been nice to have a leader like Dr. Buddy Savoy, also Dr. Greg Stewart, to kind of help all of us kind of move in many directions. The background of this really is that I was lucky enough to be able to spend a lot of time early on in my practice with a man by the name of Dr. Vladimir Janda, and his concepts are really the backbone of a lot of what I do today, both in clinical practice, as well as when we look at return to play and strength and conditioning. If you look at some of the stuff that we're going to present today, and if you look some of the things that are on the internet and really are propagated throughout both strength and conditioning, physical therapy, athletic training, and even some physicians, you'll notice that there's a functional underlay of everything out there. And a lot of the concepts of functional return to play and functional rehab really comes and based off of Dr. Janda. And a lot of people have kind of taken it and spun it off into many different ways. But his really claim to fame was that he actually looked at muscle imbalances and looked at movement from a holistic standpoint, and then was able to break it down and make it a very clinical model. You know, call him the father of rehabilitation, but really focused early on in his practice on chronic musculoskeletal pain, which you thought was a very boring and non exciting thing. But what we found was if you approached on how he looked at injuries and how we looked at rehab, it actually now is a backbone of a lot of what we do. Just a proof that I was actually with the guy. Yes, it's a very young, thin, and less hairy Andre, and that's actually Dr. Phil Page on the other side of me. And we were very lucky to be able to spend a lot of time with him, both in the Czech Republic and in the States, and really taking his concepts and for lack of a better word, westernizing it. But you know, he started off with everything. He was really looking at things that we in the States really, especially in sports medicine, don't really spend a lot of time with, from developmental pathologies with peds and also with people that chronic injuries. And what he found was that there was a profound change in the nervous system when you injected pain. And the pain and any type of pathology or dysfunction actually was able to be predictable with time. You know, and if you really want to jump into this, there's some really good books out there talking about the principles of functional movement and movement dysfunction that are based on his concepts. And Phil Page, Claire Frank, and Robert Lardner were a group of PTs that we really ran with during those times that we were kind of developing this course. The course we're going to do today is a 3-day course, and we're trying to compress 20 pounds of stuff into a 5-pound bag. So we're going to kind of run through some of this, but I think it's going to give you some good baselines and understanding of application of this concept. So we're going to talk about the principles of his functional movement. And function is kind of this broad term that really wants us to look at from inception of injury, but also inception of athlete. How do we actually maintain them and promote them? So one of his real big concepts was the musculoskeletal and the nervous system really function as one unit. And he really coined the phrase a sensorimotor unit. And they can't be separated and can't be ignored. And in many times in orthopedics and in sports medicine, we like to really specifically think about the joint that we're going after or the specific area of pain. But if we don't understand that the system works holistically, we will miss the boat. And really it's that 10% of our population that don't get better that we wonder why. The other reality is 90% of the people that we treat get better in spite of what we do, not because of what we do. So the sensorimotor system is one of those things that we kind of move away from, but you have to understand that the brain controls all. And really it's a feedback loop. It's a thing where we have sensory input, visual, vestibular, proprioceptive, an exteroceptor that is processed within the central nervous system, and we create a motor output. And it's a very pragmatic way of looking at things, just like you would as a computer. What's interesting, some of the things that you may want to kind of touch base, a little thing that we started doing here at Tulane is that just from a visual perspective, we started using virtual reality with some of our athletes who need IVs secondary to heat illness. And we noticed that we can actually put them in an environment that calms down their motor output, so the spasms decrease while we're treating them. So just a little bit of a little thing that we're playing around with that we've looked at as actually affecting our athletes in a very positive way by manipulating the nervous system through afferent input. And we're going to talk about afferent input a lot. It is really a baseline of treatment, and anything that we do from a clinical standpoint, to an athlete or to a patient, is a form of afferent input, either by touch, by treatment, by whatever. And we're manipulating an outcome because of that. So with our athletic population, most people, have a much faster learning curve. And I'll say this, in the athletic population, we have those that great protoplasm, but every once in a while we have these motor morons that, whether you like it or not, aren't very easy to actually return to play or produce, but they are effective on the field. Most of our limitations are secondary to learning curve, those higher level movement patterns that we have to keep in mind when we're actually treating them from day one. And one thing we're going to talk about is transitional movements, the things that we have to do that can correlate from the clinic or from the athletic training room, or even the strength and conditioning area onto the field. And we must look at motor programming. And once we understand all that, in our position, we also have to understand what the end goal is. Like, what are the movement patterns or the goals that are going to be required by this athlete or this body that we're treating? Basic common sense is motor control really is the motor programming, motor control of those programs is the basis of all human movement. And it's really controlled at 3 different levels. It's that voluntary conscious control, which actually is the less elegant of the 3. And then you have that automatic or that subconscious control, which is really where, Vlad kind of lived. He thought that that was where you manipulated things and created pure learning and pure movement and could affect pure movement. It's also the area where we learn bad movement and where we have things that can affect us from an outcomes perspective. That reflexive and unconscious, that's something that we can use to manipulate that subcortical level. But again, when we're talking about today, we're talking about some of the concepts is how do we manipulate that automatic, that system that works subconsciously. So, and when we talk about in Punjabi in 1992, talk ability and mobility and how they go hand in hand. And we have that kind of passive mobility concept of just, that musculoskeletal system, that skeletal ligamentous control. We have that active or that muscular system, and it's really prevalent in the rotator cuff and the shoulder, where 90% of our stability comes from a contractile component. And then the overlord of all this stuff is that neural control, and that neural control, really we need to back off and not think about what we think of as conscious control. We have to really think of that subconscious or that almost reactive or predictive control. And that's kind of where Vlad started really opening up these things, because early on in his practice, he was dealing with neurologic dysfunction and nervous system issues with cerebral palsy, polio, and that kind of thing. So that's where he learned this stuff and then started applying it in a musculoskeletal standpoint. One of the downfalls of what we do from an orthopedic standpoint is we think structure. We have a ligament tear, let's fix the ligament, and then it's all going to get better. The reality is that the fix is also a pathology. So even though we may use a patella tendon graft to fix that ACL, we actually change the afferent input of the system from both the patella, the area that we harvested it from, and also the area that we actually placed it within the knee. So those portals we drilled, the pathology of the scar, it all changes things. And scar can be a major problem because it changes that viscosity, it changes the whole system. The concept of tensegrity, which is the understanding that one part of the body affects the other, is really prevalent post-operatively. We see all these secondary things, and you see in this picture of the progression from left to right, even though that scar is healing and you can tell that that person has progressed along in their ACL rehab, you can tell that the knees look different, the patella is separate in a different way, and you go to program that's going to be affected. You can almost tell also where the anterior tib on the last picture is actually more developed and maybe working maybe overworking to make up for some other motor function within the knee. So again, taking away from the fact that we want to be less structural and more functional as we move through. One of the things that's hardest for especially clinicians and especially someone in sport to think about is that a lot of what we do and everything we do with the nervous system is based on primitive reflexes. Basically, how you are programmed from birth, what's on your mainframe, what is your binary code, what is your operating system, and this is where viruses occur. So just same as your computer, a virus occurs deep in that operating system, and anytime we have pain or pathology or movement dysfunction, it gets ingrained into that motor patterning or that primary motor function. And that's what's interesting about Dr. Janda, is that he taught us how to manipulate that pattern, how to rewrite on that hard drive. And those basic reflexes are also protective. And those basic things are locomotion, prehension, mastication, and breathing. Those things that maybe we never thought of before, but movement, how we move in space from the locomotive perspective is just something that is really untaught. It's something that's in our primary need, our needs assessment to actually grab things and control things, our needs to eat. And then breathing. How many things have you seen in the literature now where we talk about breathing and sense of self and calming and things that we can do to kind of bring our heart rate down? You know, are we upper respiratory breathers? Or are we diaphragmatic breathers, or a combination thereof? Those are all things that maybe 15, 20 years ago, we did not think about as something we should address in orthopedics, but now we're addressing it now. And we're addressing it as a part of a kind of that holistic pattern, holistic look at things. But remember, as you're evaluating someone or an athlete, you have to look at these things, you know, and perhaps breathing is something we've been missing, but we need to kind of readdress with this. But also think of this, it's still based on primitive reflexes and primitive concepts. And when we think about those transitional movements, and we think about, you know, when we look at things as the primary movement patterns that need to build up to create something truly athletic like sprinting, it really is based on what has been written on your hard drive as an infant. And it's funny how even something like crawling can be something that we utilize to facilitate something like a high-end speed of an athlete, or the power of an offensive lineman, or the ability vertical leap of a volleyball player, or those types of things. It all goes back to that binary code, that underlying program that we need to be able to step into and really maximize. If we think of sagittal plane movements as the only thing that we need to do, and we don't think about these combination movements of upper body, lower body, we miss the boat on that final outcome, that final thing of putting that athlete on the field and us doing our job and sitting on the sides and watching them perform. And even in this picture here, you can tell how running, you know, and sprinting especially, is a combination of equal and opposite, both upper extremity, lower extremity with rotation. And you see how crawling in this child, as it moves, it's equal and opposite, and it's opposite upper extremity, lower extremity. It's all based on what that child's hard drive has been, what's been written on that hard drive. So movement begins with the infant. We come back to that. And there was, you know, Vlad used to tease me all the time and saying that the best sports medicine professionals he knows were pediatric therapists or pediatric physicians, because they have studied what develops and what pathology occurs with development. Another thing he always talked to me about was, you know, there was no such thing as a healthy nervous system, just different degrees of bad. So you have all seen athletes that come in that we're either recruiting or you're seeing, and they perform on the field, but you bring them into the facility in the clinic and they look like a motor moron, and they look like, you know, this may be a really mild case of cerebral palsy or those types of things. So remember, those concepts are with us and around us all the time. Don't step away from those, because that can help with prevention and can help with understanding after an injury who is going to be the ones that are harder to get back to the field and to play. The key to all this is really engaging that subcortical control and manipulating the system from the outside in. It is the key to learning a new movement. It's also the key to preventing what's called programming fatigue. We numerous times you have an athlete has grooved a movement or grooved something over and over again. And honestly, the more efficient they become with them, the less athletic they become. And then at that point, their chance of injury goes up. It is our job not only to just produce this athlete for the field and for performance, but how do we ingrain in their ongoing both strength conditioning program and prevention program that they always have those systems in place that help prevent injury. You know, a sagittal plane athlete, we do a lot of work with triathletes in this area. And it's funny is that our best triathletes are also ones that can do a speed ladder, or that can also do, you know, shoot a basketball or run a route. And then the ones that can perform but have multiple injuries can't do anything else but those sagittal plane movements. So again, that programming fatigue becomes an issue long term. And with us looking at it from a developmental standpoint and from a Janda standpoint, we can build in programs to kind of prevent these breakdowns. The other thing about is developmental sequencing. And it's funny is that when we talk about concepts, one thing is about when we talk about joint stability, you know, a concept of joint centration would be the ability for a joint to be in that kind of neutral position prior to activity. So we've also seen these people have imbalances where you may have a pec minor tightness and inhibition of the rhomboid, and all of a sudden you see their shoulder protracted. So a protracted shoulder is not in a good position for for movement. And so one of the concepts that Janda always talked about was balance, and balancing between both anterior muscles, posterior muscles, concepts of flexors, extensors, and we're going to kind of go into that. But creating that initial position so that movement can be pure, movement can be optimal, and it always starts with a starting position, which is where posture comes in. Posture, posture, posture. How much money do we spend on posture shirts? How much money do we spend on postural taping, or reminding our athletes of posture? It's that starting position that's important. Another thing is that fixation points, and it's kind of punctum fixum is kind of a check term, but what it basically is stability. Can we create inherent stability? Now, we always think about stability with the shoulder, but then you start thinking about things like the core. And core is a great word, right? But what the hell is the core? Well, the core is a concept of muscle firing, a concept of synergistic muscles that create stability to allow the extremities to move. So a stable base is really where we start. And like we say with a lot of our athletes, we're going to build you like we build a tree, from the roots up. So we don't start with the leaves, right? We always start from the base. And this is kind of that initiation of that fixation point. And then back to the coordination of agonist, antagonist, and those concepts. Very rarely in a post-op ACL do I worry about hamstring firing from day one. I'm always worried about what quad. I'm always worried about the quads that activate. I use all these great things to get the VMO and the quad firing again. Part of that is the fact that yes, we've affected that kinetic chain. Perhaps we affected the patellar tendon, but really it's also a reflexive response to an injury. The quad shuts down, the hamstring becomes dominant. That's the way it is. If we don't restore that synergy and that balance, you're never going to get the quad to come back because of reciprocal inhibition. So again, coordinating agonist, antagonist, front to back, side to side, are all these things that we need to kind of keep in mind as we go forward. And one problem that we have in a lot of what we do is we worry about that sagittal plane, that going forward activity. But rotation and movement in multiple planes is a thing we have to keep in mind. Not so much, not even just in the rehab phase or in the strength conditioning phase, but also the performance phase. How do we maintain that performance? And what's funny is if you manipulate the nervous system the right way, your effects on the nervous system can stay. If you don't, you will eventually have breakdown if you're just repeating the same things over and over again and don't do things to be more dynamic or change that nervous system's reaction. We talk about, crawling, and we do bear crawls with everyone, and you can kind of see where, early on in the phase of teaching this is kind of a basic primitive position, okay? But as we progress that, and this is kind of our baseball team, you can see where as they train, you can see where crawling can become something that is a concept that is carried over and become more and more efficient. The best part about all this is that when you inject primitive movements, these athletes never get used to them. These athletes always feel challenged. If you can continue to always put in things as part of their either warm up or their daily routines, the challenge is the thing that kind of maintains that magic. So crawling, believe it or not, is the primitive position for either throwing or hitting. So if you are throwing a baseball, swinging in volleyball, this is kind of where this is the hard drive. This is where it's written. This is our binary code 01101. So again, going back to what the body was never taught, what it was always originally programmed, gives us kind of an avenue back into the brain to make this happen. So as we look at other things, Jan always talked about, we talk about agonist, antagonist, and from a functional perspective, he used the words postural and phasic. And the reason I'm kind of going into this is that a lot of times when we look at treatment, you're going to find that as we look at these muscles and look at these two different systems that make up, there's an old saying Labbe would always say, he goes, how many muscles in the body? And you'd say, 300, whatever, how many hundreds? He would say functionally there's two. There was giant flexor and one giant extensor, and life is just firing, is really just the two fighting against each other. So, you start kind of dipping into this stuff and you start hearing stuff that seems a little bit like Eastern medicine with yin and yang and that kind of thing. So don't hang up yet, just stay with me and we'll work you through it. So from a postural system and from an evolutionary system, really that postural system is older and it's based on flexion. Also think about this, when a baby's born, okay, what is their primary position? Flexion. So fetal position is actually flexion. Elbow flexion, knee flexion, hip flexion. Flexion is more postural, but it's also more core based. It is the underlying basic component. With those postural muscles, they tend to be short. They tend to want to shorten. They're also the quickest to activate with many things, but especially reflexively with pain. And they're less likely to atrophy, and all usually one joint muscle, as opposed to the phasic system, which is a learned system. It's younger. It's after birth. Okay. It's more of an extensor, the stabilizers. They tend to be lengthened. They tend to be muscles that tend to become weak or delayed in activation. They're more likely to atrophy, and they also are more like two joint muscles. But they have to function together. And if you go back to this slide, you got to think of the postural system as the big brother, and the phasic system is the little brother that gets beat up all the time. And this is what we see clinically, functionally. This is what we see all the time. And there's no such thing as independent function without the two. They must work synergistically together. If we allow that big brother to always be dominant, there will always be pathology, or we will set ourselves up for pathology. Injuries that occur without a true event. So my endurance athletes, after 2 miles, my patellar tendon starts hurting and I can't run anymore. Well, what is that? That you have to start going down the road of a functional lesion or an imbalance going on between these two systems. So, and when you look at these upper extremity postural chains from flexion, internal rotation, adduction, pronation, and that phasic chain, extension, external rotation, abduction, and supination. Well, what does that look like? It looks like PNF, proprioceptive neuromuscular facilitation. So the Czech Republic back in the day in their European medical model, this was where it all comes from. So this is Shirley Sarman stuff. This is thru therapy. This is all pediatrics. So, and we call ourselves doing PNF and stuff in clinic, that kind of thing. But if you really delve into it, you have to kind of use this as your pattern and making sure you're doing it. And those postural chains with the lower extremity, plantar flexion, inversion, hip flexion, internal rotation, adduction. Again, all those are your main muscles. If you think about it, these are all the muscles that if I kick you in the stomach, you're going to flex all these muscles at one time and inhibit all these muscles in the phasic chain. That's just the way it is. It is this pattern that is dominant. So, bottom line is you can also kind of put it as to flexors versus extensors. But if you basically look at it in this way, in the upper quarter, those tonic muscles are basically pectoralis major, upper trapezius, levator scapulae. These should sound familiar as muscles that you're always working on to inhibit. They're always in spasm. Okay, I've never told a patient, boy, your upper trap is loose. I've never told someone with TMJ, boy, your masseter is real loose. I've never ever said, boy, your soleus is so loose. We need to loosen. We really don't need to work on that. It's always these different things. Hamstrings, iliopsoas, tensor fasciatum, piriformis. This should start being an aha moment for you that these muscles are married together in a kind of a synergistic group that is dominant. Okay, and going back to, we said earlier, those tonic muscles are prone to tightness, and those phasic muscles are prone to weakness. So the other thing to keep in mind is that the tonic system will always inhibit the phasic system. It won't happen the other way. The phasic system, if we wake it up, will bring the tonic system back to steady state, but we will never overload it. So you will always bias yourself to uptrain the phasic system while inhibiting the tonic system. And look at the phasic system, what are the things we always fight over to fire up? Serratus anterior, okay, the deep neck flexors, the upper limb extensors, perineals, okay, glute med, glute max. If you had to really build a body around a muscle that you would want to function, it's got to be the glutes, okay? Transverse abdominis. Remember, these should all look very familiar to you as the muscles that we're always trying to make wake up, the muscles that we're always trying to make turn on. So it becomes one of those things that this is really where we live from the standpoint of an activation standpoint, and even from a strength standpoint. Keep in mind, when we look at strength and conditioning program, these muscles should be things that we think about of always trying to activate. But also remember, most of these muscles are muscles that act reflexively. They're there. I mean, most of my athletes, if I ask them to fire their left glute max by itself without firing the hamstring, they kind of have a brain fart. They don't know what's going on because they're going to be hamstring dominant first. Okay. If I had someone fire their transverse abdominus, they couldn't find it with both hands, but as a muscle that fires automatically, that needs to be something that's somehow facilitated. What's interesting is that with that tonic system, what do? We're always treating it soft tissue wise. And look, if you want to go into treatment and soft tissue work and all that great stuff, and look, I've been Graston certified, dry needling, cupping, myofascial release stuff. I've done it all. So all that is, if you numbed it down and dumbed it down, it's just a big afferent stem. And we're using a big afferent stem to override the tonic system's tone so that it kind of inhibits itself and goes back to steady state. That's it. You can describe it as different things, and we can add research, and we can do all these great things, but really what we're dumbing it down to is a big afferent input. And we see the body react to it. And you know, even with chiropractic manipulation is a big afferent input in the system, and it's almost like hitting Control-Alt-Delete on your computer. For those of you who are old enough to understand what that means, but it's a reset. It's a basic reset to get you back to steady state to then facilitate a good movement. Your facilitation components goes to the Phasic system. We're always trying to make it work, okay? Activation, exercise, but doing exercise that may not be your typical movements, but things that are going to have overlying capabilities of inhibiting that tonic system and bringing the body back into balance. Maybe that's the kind of the key to all is how do we bring it back into balance and make it so that at that point in time, those motor programs we've been kind of working on can work more efficiently. Again, without a violent act, without an incident, without a crazy incident, most of the soft tissue injuries we see are these injuries that come out of nowhere is because we've overloaded the system or there became this imbalance that we didn't know what was happening. Now, as we kind of move into this, some basic postural things, some basic, developmental things. You look at upright posture and locomotion, it's kind of the basic for muscle function. And if you think about reciprocal gait, and gait and crawling and all that great stuff are all, that's kind of our baseline of movement, right? So initially gait movements and all that stuff, that's how we run, sprint, that kind of thing. So it's funny it how the body reacts if in a pattern that connects the upper extremity, lower extremity, but even more so contralaterally. So my right arm and my right shoulder, my right hip are married into function. That's just the way it is. So the other thing is postural stability is a reflection of the function of the sensorimotor system. So again, the whole concept of movement is controlling that center of gravity about some base of support. That might be bipedal base, that might be two hands, that might be 4-point with crawling. So the other thing to keep in mind is that balance. It's a concept and a thing that we think comes naturally and normal. But honestly, in our programs, we should always do things that facilitate balance, that facilitate postural stability. And when I look around the country, we visit and we do things, and we look at some of the better programming out there, they actually take out components of the program and make sure that they integrate concepts of balance and concepts of balance in a barefoot training method. Why? Because barefoot is better for the system. In this video here, you're going to see that we're going to put this athlete in kind of a step position, and I'm going to limp my butt around him, and I'm just going to put a pressure on his anterior shoulder. See, very strong. Now all I do is take the opposite hip and put it back into an extension position, and he loses all that strength that he had. It's just a party trick to let us know that that shoulder and that hip are married together. He also didn't like the fact that I broke his right shoulder because he's a strong guy. But if you look at that concept and then marry it over to what really matters, and I've got this soft spot in my heart for baseball, hip position, shoulder position, it's all based on that. So, here at Tulane, one of the nice things that our head baseball trainer, Max, and the coaches let us do is we started integrating this hip activation model. And what we find is that more times than not, when we have an athlete that breaks down, an upper extremity breakdown, it occurred in their lower extremity first, or it was synergistic with the lower extremity. So a single limb stance, a single leg squat, hip abduction, manual muscle testing. The hips must be addressed as we go. So when it comes down to prevention, the butt's king, the hips are king. When it comes down to return to play or return from injury, the butt and the hips are king. So our post-op UCL that's still in a splint or a sling is doing hip activation first and foremost, okay? They're doing single limb stance first and foremost. They're doing hip mobility first and foremost. Why? Because we need hip stability, but we also hip mobility. I mean, there's a direct relationship between stride length and velocity in baseball, okay? And if they don't have the right stride length, the athlete will rob from Peter to pay Paul to get there. But with a big stride length, you've got to be able to create enough momentum to bring the center of gravity forward to finish the pitch. So again, looking at, always remember that the upper extremity and lower extremity are married together. If you forget or just completely lose it, go back to how a baby moves as far as with crawling, and you're going to see that synergistic movement between the two. And again, if we looked at lower extremity, upper extremity, and we look at basic concepts of rehab, if I was going to do a posterior shoulder activation or shoulder external rotation, why would I do that when that's really not a synergistic movement? Why not add something that's going to, as I'm doing a reactive isometric to this right shoulder, I'm also getting left hip activation, which it's its cousin. Same thing with if I'm doing serratus presses or really pressing early on in rehab, why not move into the synergistic pattern that the athlete's going to have to get into, okay? So those are the things to keep in mind. We can do early on dynamic movements that facilitate and start working on our in-game pattern early on without doing anything detrimental to the surgery, anything detrimental to their early on rehab. Another thing on the left-hand side, you see his hand is open. Hand open training really early on with cuff training, also with serratus and rhomboid training, it's a synergy. So hand closed actually makes pec minor and pec major fire. If pec minor, which is a very dominant muscle, and pec major, which is a very dominant muscle, fire, guess what? The posterior chain is going to be inhibited. So why would I in any way use closed hand chaining early on? Do I migrate to that? Yes. But our athletes have enough time in their whole athletic career with closed chain training, okay? The other thing is that, afferent input is kind of the key. So we see athletes all the time that have poor foot positioning. They may have asymmetrically flat feet. I'm not saying flat feet are bad. Let's be clear. Some of our best athletes have flat feet. Asymmetrical flat feet, they maybe have issues there. The other thing to keep in mind is that, Nike did a great thing for us, and our shoe companies did a great thing because we have the best shoes in the world. And in the world, the first thing mom and dad want to do when the baby's born is get them some little shoes. Well, realistically, barefoot training and training that actually allows the afferent system to kind of be challenged is something that's good for the system. And if I had to give you guys a shortcut or something that you can just implement tomorrow, find ways to have your athletes work on labile surfaces or surfaces that they can't predict or surfaces that are unstable or surfaces that have an issue, and you will make a difference in their whole firing pattern. I mean, that's kind of it. And it's like a computer. If you put, crap in, then crap's going to come out. But if you get good system and good afferent input in the system, good outcomes are going to happen. So, those outcomes come from all over. But remember, if we have any issues with the capsule of the ligaments, any issues with the muscular receptors or the cutaneous receptors, it can affect that afferent input. But boy, you start really playing around with how some of the things that we do every day affects things. Kinesiology taping. There's tons of research on how it works, and it's a big afferent input, right? But it's something that affects the skin, which is kind of the biggest organ in your body, and it has huge amounts of afferent input into the system. So kinesiology taping can actually help us, especially in the rehab part of things, to kind of bridge that gap from rehab to performance, because it helps us, support the system and maybe create new pathways of afferent input so that the body, which may have lost that because of a ligamentous tear, a capsular tear, any of those things, because even if we have surgery to repair these things, what was there is no more. I mean, our best surgeons try and be as least invasive as possible. And Dr. Savoy, who does miracles with this stuff, once said that if we address the body in a way that it likes, and we can be minimalist in our approach, then our surgery will not become part of the pathology. And that's kind of the key. So we all see this, that if you come with an injury or come with some form of change in mechanoreceptor or proprioceptive input, we have a challenge there, and we have to kind of add that into what we're doing. Even if it's an upper extremity athlete, I'm telling you, balance training for our shoulders and elbows is just as important as balance training for our knees, hips, and ankles. So keep that in mind. Core, any low back pain, any SI joint issues, it's all based on that stuff. So keep that in mind, that you have to address those things as we move forward. And it goes back to the kind of feedback loop. But what's funny is Freeman and Wyke and Bullock-Saxon talked about it. But what was interesting is that there's just things such as a feed forward mechanism. Okay. So we can talk about these receptors and stabilizers and how the body reacts to something that we put in there. But when you initiate movement, it's funny that your brain actually has a way of predicting the movement before you consciously really initiate it. And that's kind of that feed forward mechanism. And the game you play with that is, you know, if you ask someone if they're standing with their arms by their side and they do shoulder abduction, you know, what's the first muscle? You know, that's the trick question, right? So if it's right shoulder, first muscle, we'll throw it at our students and they'll say it's, you know, subscapularis, it's deltoid, and they'll get crazy. Oh, it's serratus anterior. It's actually contralateral transverse abdominus, because it has to fire to stabilize, because when I abduct, I change the center of gravity to the opposite side, and we could actually cause a side bend. And, you know, when you get into, and we're not going to go into Janda's evaluations and any of those things, but those are the subtle things that he would look at to kind of predict if there was a motor programming problem as we went through it. Okay, so just kind of keep that in mind. But when we look at those, you know, preemptive strikes, those feedback and feed forward mechanisms, then you start looking at these dynamic rotational movements. Then a shoulder external rotation and kind of this forward flex position changes things, because I'm also doing abdominal training on one side. This ball lift, which is a PNF ball lift, and I'm sorry the video's not working, but if you look at that, and the athlete is thinking about this ball moving from between his legs above overhead, but really what the body's thinking about is, boy, my left glute is really fired up. And in baseball, if you think about it, you know, especially with pitching, you know, your glute is where things happen. So that backside hip generates that momentum towards the target. That backside hip is the thing that generates that power and velocity that's going to be released by the hand. It's not the elbow, it's not the shoulder. Those are just basically transfer mechanisms. So keep in mind that anytime we're doing this stuff from a warm-up perspective, from a training perspective, that think about the nervous system first. If we can make the nervous system fire early, we become better. If we can make the nervous system become active early, we prevent injury. We actually set our athlete and set our people up for success. The other thing we always are concerned about is that when we're trying to return an athlete to play, if they have an incident where they feel or they do something that reminds them of the injury, we may have a bigger problem on our hands, because then they become careful, then they become worried, then it becomes something that is like, is a you know, a between the ears problem. And we can't, you know, the old saying, you can't drive careful. We can't have a careful athlete. We have to give them a baseline and power, and we have to integrate them back into their sport in a way that they do not have any hesitation and they do not have any worries about returning to play. So proprioception regulates posture and stability, and really Leppard and Flew talked about it. You know, what is proprioception? It's kind of this bastardized term everybody talks about, but really it's that cumulative afferent neural input into the central nervous system. And when you look at these two positions, it's from the feet, but it's also afferent input from where his hands are, from the movement that's actually loading his system. It's all coming from this whole system here. So, and again, with postural stability, if we divided it back up into those two basic things, it's, you know, the peripheral nervous system and the central nervous system creating this kind of component where we have motor output, which is basically a subtle component of stability. And again, visual, vestibular, proprioceptive, and exteroceptor. And if you think about this sensory input bubble, think about our post-concussive athletes. Think about what's going on with them. If we return them to play at a point where their sensory input and they're not programming, and their central nervous system isn't programming what comes in through the system, what if they have you know, we can end up with an ACL. I mean, those are the types of things that you have to kind of think about, you know. It's a much bigger system than that. Just because an athlete can squat 500 pounds, I could care less. Can they move in space? You know, what's their single limb stance test like? Can they do a single limb squat? Can they, do they look like they're an athlete? That's the kind of things we kind of start looking at. You know, it's funny, when it comes to treatment, you know, the three, you know, and Vlad, you know, Vlad, he always talked about the three biggest areas that that regulate posture and movement, it's the OA joint or the upper cervical, it's the SI joint and the sole of the feet. Okay, now think about that. How many of us, upper cervical pain, upper cervical issues? Why? Because there's a huge amount of afferent input to just keep the eyes parallel to the ground, to the horizon. The SI joint, I see tons of times that we are seeing treating, hey, I'm out of alignment. We hear those words from our athletes. I mean, the SI joint, why is that an important area? Is because a lot of the forces from the lower extremity kind of come together there, and it's a transfer station. It's a hub. It's a hub of force. And if you disarticulate the SI joint, you're going to see how its articular surfaces are undulating and has all of these different things, but it's inundated with both ligaments and it's inundated with proprioceptive feedback into the system. And we could go on and on and on about the foot. I mean, Freeman and White talked about it, but if you look at, there's such a thing as reflexology, right? So we can treat, the colon from the foot. So the foot's afferent input is important. And again, why we should look at things that help stimulating our body from that area. Now, with postural stability, we look at afferent input, but looking at these three areas, and a lot of times it's this area where there is a concentration of ligaments, a concentration of tendons, and a concentration of neural bundles that produce information into the system. Those afferent areas like the SI joint, the OA joint, and the plantar surface of the foot, you look at things, it should never be taken for granted that it's one and not the other. Early on in my practice, I remember we used to have, physical therapists that were, I'm a craniosacral therapist, I'm an SI person, I'm an orthotics person, which means if you came in with jaw pain, the therapist was looking at your first ray of your foot. If you came in with neck pain, they'd look at your SI joint first. If you came in with, low back pain, they were doing OA modes. Well, were they wrong? I don't know about wrong, but I also know that they got results. And what they did was they affected a huge afferent component of the body. They put in afferent input and made the brain subcortically react. And could they change tone? Yes. Could they change tone systemically? Yes. Remember, it's a systemic effect. Do not think that a pathology in the knee doesn't affect the cervical spine. Don't you think that a pathology in thoracic spine doesn't affect the foot and ankle. It's one of those things that you have to keep in mind. And we go back to SI manipulation and mobilization. I can tell you right now that I do mobilizations and stuff to the SI joint. I don't know how much I'm moving it. Okay. What am I doing? What I'm probably doing is creating some form of afferent input through this major ligamentous thing, and I'm changing the tone of the muscles that are around it. So more times than not, I'm going to have either increased tone in the piriformis, increased tone on the hamstring, and inhibited tone in the glute max. I'm going to have increased tone in the hip flexors and inhibited tone in the upper quad. That's Janda's lower cross syndrome. If I do something to affect that or affect that joint, I'm going to affect tone in that, right? We still get the same effect that we have someone who has a fused SI joint. I can still do those types of things and still get an affect from it. So just kind of keep those things in mind. Dry needling in this area works tremendously, but again, what am I doing? I'm putting afferent input into an area of one of Janda's spots that can create a global effect. So if someone comes in with a terrible upper cervical problem, you can't touch them with a 10-foot pole. Maybe you do SI stuff. Maybe you use plantar surface of the foot stuff. Maybe we kinesiotape their arch. These are all things that you can do to affect the system as a whole. Now, our trainers at Tulane really thought I was crazy when they asked us to order these Labbe surfaces, these pads that we have in the training room. So imagine you wanted a sand pit to train your athletes in, but you didn't want the mess and the hassle of this. Well, now we actually have these interlocking pads that create kind of that same Labbe surface. And you can be a smooth surface and you can have a textured surface. And this textured surface actually creates a little bit of a noxious or a painful stimulus that the body has to react to. And what's interesting is that you walk on this for 10 to 20 to 30 seconds, there is a difference in your tone in your lower extremity and somewhat in your upper extremity. So again, another tool that we use as a transition tool. This may be early on in rehab for afferent input in the system. This could be something we do preemptively before an outing. This could be, our baseball players would come in and walk on this barefoot before they would go into a bullpen. Who knows? But it's all these things that you just kind of put there. And the nice thing about this is that we could have these things in the dugout. We have these things, out there in the near the bullpen. So we could do things to kind of accelerate waking up that nervous system. And again, it's affecting in that nervous system. And you can walk in the gait with it. But just like the first day you go to the beach and your feet are sore the first day, but after a few days you get used to it. Well, what happened is your neural input got used to that new surface. You became more stable within your foot. And actually you disperse your base of support, you disperse your center of gravity over that base of support better. So keep that in mind as just another tool that you can use. But the other thing is, keep in mind is that reflexive stabilization may be the most important thing that we do when it comes down to injury. And if you look at things like the ACL, how many times do we have these athletes that you see with no contact, no preemptive movement, that all of a sudden tear their ACL? I think we had a player last year tore their meniscus just running in a straight line. So if you go back and looked at that athlete long term and looked at really their body type, there were some developmental issues in that person's nervous system. So could we have prevented it? Probably not. Could we have looked at it maybe differently and maybe implemented some things differently in that one athlete's program to uptrain his nervous system? Probably so. So keep that in mind. But reflexive loops between the mechanoreceptors and the joint stabilizers is one of the main keys to things. And if we broke down one of these voluntary muscles, these things, we look at what exactly are these muscles that are underlying, that are kind of subcortical, that are always there to help stabilize and preemptively fire. And this is that kind of the slide that really, if you look at shoulder movement and transverse abdominus movement, you can see where the transverse abdominus is something that fires preemptively before shoulder movement. We have to be able to train in that way. If it did not fire early enough, it would change the fixation point or the point of the shoulder and could lead to other things, So is this a muscle that I can put a weight on and fire? No. Is this a muscle that I can train reactively? Yes. So it really changes how we look at strength training even as well. A good friend of mine, Joe Danos, who's the performance guy for the Giants, we've had long conversations about this, because how do you train something that is a reflex or a preemptive muscle? Well, you have to find the things that really stimulate the nervous system in similar positions as the end result, and then add some things to kind of challenge the nervous system there. It's not a matter of weight, it's a matter of afferent input. So, one of the old things is the unconscious reaction speed is really more important than anything else, and not really strength. So you look at these three athletes, and I'll put quotation marks about it. Out of these guys, number one, I could probably outrun one of them. I ran in a serpentine fashion, but is muscle the end all be all? Probably not. If a pitcher looks really good on the beach, he's not going to last long pitching. Okay. And we can talk about all these other things and how the balance and everything else actually progresses. But even in these things, and Nashner talked about how, even balance from ankle synergies of forward, backwards, that kind of thing, has a predictive model where if I sway forward, my lumbar paravertebrals fire, my hamstrings, and then my gastrocnemius. I sway backwards, abdominals, actually anterior tib, quad, and then abdominals fire. If I do a hip hinge first in any of this stuff, I actually show that I do not have good reflexive stabilization. So just a sway test, even single limb stance test, could be things that we use to kind of predict injury as we go. Again, just kind of a quick challenge that we see here, how we can use perturbation trainings to fire this athlete. And as soon as I change his base of support, notice that his small oscillatory movements change. But then if I want to really start challenging him and add some reflex stabilization in the pitching position, I can migrate my way all the way to a ball release position as a pitcher. And he's not a pitcher by trade, so don't take him apart. But this is kind of how you kind of progress. So, as a few other things to keep in mind, that functionally muscles work in together in slings, loops, and chains. It's something we have to keep in mind. And Benninghoff talked about this, that there are abdominal chains, there's lower extremity chains, upper extremity chains, how all these muscles work synergistically together. we ever break the muscles down and try and just say that it's one or the other, we miss the point. Okay, we miss the point. If you look here at how the serratus and the rhomboid are firing, pectoralis and internal oblique fire, or internal oblique and glute med fire, external oblique and AD adductors fire. Those are all slings and chains that work together. And if we think of the body as that way, we can actually train it and rehab it even better. This kind of is kind of that lower extremity muscle chain, the squat chain. And you know, I'll say this, I think the squat is probably one of the most influential movements that you can do. But a squat can be defined many different ways. And I would say that this is a primitive component of a squat. These are monster walks with serratus presses. And these are things that we would do with an upper extremity or a lower extremity athlete early on in rehab. But guess what? This is also a great preemptive exercise to do before performance, depending on what they do. We see a squat progression where, you know, we like using TRX to kind of progress that athlete to other things and then move our way all the way up to an overhead squat. I think from a nervous system standpoint, the overhead squat may be the most challenging thing to do. It's the hardest thing to teach someone. And it's also a great example of a non-weighted movement that create huge neurologic feedback and neurologic output. We do not teach the snatch typically in an athletic competition or an athletic training, a strength conditioning program for a Division I athlete. It's really, you know, in my opinion, should be geared towards the true Olympic lifters, but this is a great position to be able to get into and really is a good indication of true athleticism. So what I also like to do is these integrative positions, the integrative movements that actually can lead to, you know, integrating what we may do in a sagittal plane and start moving in these rotational and these diagonal planes. And you see here, you know, I've got an athlete that's more kind of a bodybuilding type body that is you see he's having somewhat difficult getting up and out of this position, even though he's athletic. The more, if I go into a little bit of a different looking athlete, you know, this person is someone that I can put in a more dynamic, challenging position and put them on the field with less issues of having to worry about them not being able to move in space. And I'm also, again, utilizing what? Our primitive positions, okay? It's also a start, you know, speed comes from here, power comes from here, strength comes from here. I'm using a primitive position as a transition. So I may have this area set up next to a squat rack. So I may have my athlete front squatting, okay, move straight to this as kind of a superset position as an integrative movement. So now I have something that I know now is integrating the nervous system early on. And we can talk about, you know, flexor and extensor synergies and really hitting all these things, but always remember that muscles never work in isolation. You know, if the squat is great, the press is even greater, the push-up's even greater. And if you look here, this tells me that I could use a push, press, or even a plank position to fire what? My abdominals, fire my quads. So this may be a great exercise, guess what? For my post-op knee, okay? I know that reflexively the quad has to fire to maintain this position. Even if I'm not getting a good activation consciously of a quad set, maybe I get it in here. And this is kind of an example of kind of a press position. I'm sorry, a squat, a progression of exercise. So I can see where he's just using that to kind of fire shoulder activation reactives here. We're doing a single arm rotational, again, in a stride position. And then as I progress, I can get into kind of a plank position where I'm actually using lower extremity movements to challenge even more. And then I can actually move to progression, a push-up progression to shoulder touches, push-up progression to side crawls, and a push-up progression to up downs. And again, is this the primary part of my rehab? No, but these are all component movements and component things that I have to keep in mind. So really, kind of to start summing all this stuff up, you know, Janda approached this thing as a sensorimotor system as one entity that controls movement. He identified these two basic groups of muscles to function, and they affect posture and movement. And we have to talk about the proprioceptive and reflex stabilization programming, and looking at the body as a whole, and looking at motor ingrams and motor chains and slings and loops and all these other things. It sounds complicated, but if you look at the body from a system standpoint, always remember about your afferent input, always remember what you're looking at from an output. It's a great way to integrate into what you're doing. Nothing that we're doing right now in our athletic training rooms, in our strength conditioning programs, in our physical therapy, none of it's bad. I just think there's different degrees of good. So I think that if you start adding these things and adding this from the standpoint of understanding, you will actually make your outcomes better, your teams will be better, your injuries will either be less or your return from injury will be much, much, much better. And I'll just kind of touch base real quick. I'm a big Olympic guy. I love the Olympic lift mainly because it actually uncovers and actually is a baseline of a lot of great things. Always remember this, there's a huge difference between muscle action and muscle function. Many times I've got a quad that can't fire, but they can squat, or even a knee that really early on is running, but it looks like crap when you try and isolate it. Remember, there's two main rules of thought. There's structural and function. We should be more on the functional side without forgetting about the structural side. We have to have good structure for good function. Going back to the old hardware, software thing, remember the software is that's where the devil is. That we can fix a knee, but if we don't understand how to make it function, we lose it. Again, working through all this, looking at from the standpoint of what is our traditional look at things. Used to be a structural approach, and now we're moving into this more functional approach where we're looking at kinetic change and that neurologic input. Always remember this, improper afferent input will all affect movement. It's going to lead to faulty patterns and to injury. So if the joint's bad, everything's bad. If the afferent input's bad, everything's bad. You could have this type of winging because of a labrum tear. Did I do anything to the scapula? No. But when I injured the labrum, serratus shut down. So always remember, we still have to keep in mind that you can't just jump into this and not have a healthy joint. Tons of research on how this works and really how it kind of moves. Janda would always say that the pelvis is kind of the core or the key component of this. Always kind of keep in mind that that's there. When you look at the pelvis and the kinetic chain, remember that the pelvic floor, the transverse abdominus, and the diaphragm really make up that kind of pressurized box that allows us to create kind of an anchor for extremity movement. So we have to have core stability for any type of extremity strength. And really that dysfunction leads to other issues. So even though we may have an upper extremity dysfunction or a lower extremity dysfunction, we have to address these basic concepts. And again, remember, it's a central nervous system thing. I promise you, any injury will start to actually mimic a central nervous system lesion. So we talk about decorticate posture, decerebrate postures with head injuries and with spinal cord injuries. If you start looking at a post-UCL, the bicep will always have increased tone and the tricep won't. They will want to go into the kind of that flexor synergy, and the flexor mass of the form will always have increased tone, even with a perfect repair. So always remember that once we change the anatomy, forever, we will always have to be fighting the central nervous system response to it. Create chronic muscle imbalance that lead to issues in motor programming and leads to this kind of vicious cycle of, we have pain, we have a muscle imbalance, impaired movement, and this synergy that keeps going are the things that we have to fight long term. So, this is not an evaluative course, mainly because it needs a lab, but if you can assess early on and you can look at movement patterns, and I love Voight stuff with functional movement screens, all those things are great. But if you spend some time looking at it you can actually start to identify patterns. And once you get good at it, you can see a kid walk across a room and see that there's something going on, like their program just ain't that right. So these are things that to keep in mind. Don't just stick your head down and jump into a painful area. Many times, the pain is really not where it is. One other thing to keep in mind and this is where, some of the better strength coaches that I've worked with, and we talk about things, a lot of times when you push the musculoskeletal system too far, and we go past neural control, that's where it happens. The other question is there such a thing as neural fatigue and musculoskeletal fatigue? I think it goes hand in hand. You have to keep those things in mind. You know, if you figure out the best way to strengthen the nervous system, let me know. I think we're still trying to find out, but I still think it's an effect of manipulating afferent input into the system. You know, this has been great. This has been, I kind of get long-winded with this stuff because I'm somewhat passionate, but you know, the reason I'm here is because I really had help from a lot greater people than me. You know, Dr. Janda, Dr. Buddy Savoy has given me this opportunity with Dr. Greg Stewart. I hate to admit it, but Phil Page, who's the head of research now for Franciscan University in Baton Rouge, he was kind of my cohort and all this stuff. We probably did some of the early on work with Janda and we're able to spend all that time with him. Dr. Drez and Russ Payne, you know, at 16, 17-year-old working in their clinic, I learned a ton. The great Dr. Andrews, and then, you know, our group here, you know, Albie and those guys and Chapel and all the athletic trainers have allowed us to move into this space and help me do what I do. So, and a shout out to some of the, you know, I've learned more from strength coaches than I have from almost anyone else. And me and Coach Danos and Matt Bruce is the guy you see in front of you. He was an Olympic lifter that worked with Coach Hatch at Baton Rouge. He's still a great strength coach right now. Just, but you start looking at some of the movements that a 165-pound lifter can do. And what do we have here? Is it a very powerful human being? Yes, but we have a great nervous system. That's kind of the key. Tess, I think that's it.
All right, thank you for presenting, Andre. At this time, we are going to go through the Q&A section. So we'll just start at the top, and Andre, I'll read them off. Let's see. Can you comment on the movement fatigue and any possible relation to early sports specialization in youth athletes?
Yes, so I think that, we didn't really touch on that, but basically, specialization in sport has really been the one thing that I think has really hurt us. We do not create great movement patterns in our children at an early age. So I think that some of the most dynamic things that are out there right now are kids who actually play multiple sports. You know, the other day we had a 11-year-old that came in who's having elbow pain, and I went to go throw a baseball with him. I said, "What positions do you play?" He goes, "I'm a PO." I'm like, "What is that?" He goes, "That's a pitcher only." I'm like, "You're 11. You know, how can you be a PO?" So I think that, you know, unfortunately, we're going to be busy in the future because more and more kids are moving into these specialized sports. It's being driven by money. It's being driven by mom and dad wanting the next, you know, Nolan Ryan. What reality is that in the pro level, our greatest athletes and our pro players played multiple sports. So I think the different things you give a child to do, the better whole athlete they're going to be. So.
All right. The next one, have you heard of reflexive performance reset, and do you have an opinion about it?
I haven't heard that particular name of it, but so I can tell you this, it kind of goes back to Janda's concept of kind of a control-alt-delete thing. What you want to do is overload the system to a degree and see how it reacts. So, you know, there's a lot of great words out there and people have coined phrases about this stuff, but really it's how you get the system to go back to more of a primitive movement. We think that when you implement movements that the body really has already ingrained in it as part of your transition movements, you do that reset and you can create more of a balance in the system moving forward. So. Okay.
Regarding reflexology, do you use that much at Tulane, and would you suggest more use of that in intercollegiate athletics?
So I put that slide up there to get that kind of a question. So reflexology, I'm not for it, I'm not against it. I can't really tell you that I can affect the colon or any of that stuff with this thing. I think it's been around forever. I'm going to tell you this, you know, 5 years ago, 6 years ago, I didn't think I was going to be doing dry needling. And I'm doing it like it's going out of style. I think that affecting the foot is something you have to do. I think there's always points in the foot can affect the whole system. I think that it is an important thing to do. What honestly, the way we look at it is we look at it with those pads with the multiple knobs on or nipples on it that actually can affect the system and create that afferent input. So I agree that it's there. I wouldn't call what we do reflexology, because that's a completely different mindset, and that's also a specialty. But I do think you have to affect the plantar surface of the foot more than we do now. Can't hear you on mic.
Along those same lines, someone asked, on the reflexology surface or pads, would it make a difference if the shoes were on when we're walking on the reflexive surface? And how did that surface work for baseball?
So, the surfaces, you won't get the effect of the knobs with your shoes on, but you will get the effect of the softness of the surface. And we felt that it helped a ton with waking up the hips, waking up the hip abductors, and waking up the stability of the lower extremity. We really promote, hey, take your shoes off and let's do this. Now, middle of the game, no, we're not going to do that. But what the idea is, can you do things to kind of affect it? It also is a very clean way to have a sand pit. You know, it's a very easy way to implement something like that in the clinic, in the weight room. When we were with Coach Danos, we actually would have, so if you ever seen an Olympic lifter warm up, it's a series of movements they do on the platform with the bar. And what we did, we implemented, and we kind of made up, we had a box of rocks, and actually smoothed rocks out of a stream that we had in front of the platform. And our guys would do front squats and overhead squats with the bar over it. And once they did that, then they would put their lifting shoes on, and they had a tremendous change in how they felt. They just felt that it accelerated their warm up. And that's kind of where I guess we're trying to do. We're accelerating the warm up. We're hastening their time to performance by using this stuff. So.
All right, we will take a few more. How would you suggest that someone would perform a neuromuscular evaluation on a patient that was mentioned that tore his meniscus running in a straight line?
So that person, we would start with a structural assessment. So we would look at their standing posture. We would assess tone in the muscles are affecting. So we would look at hip flexor tone, hamstring tone. Then we would look at balance. We would have bipedal stance balance, tandem stance balance, single limb stance balance. We would then also look at reflex. We would patella tendon reflex, Achilles tendon reflex. Are we hyper reflexive? Honestly, we would start looking at things from a cogwheel perspective. We would delve into our true neuro assessments to see if I have someone with a heightened amount of tone or a heightened amount of baseline neural activity. That's going to tell us if this person is on the scale of more hypertonic, as opposed, and on the flip side, someone who's hypotonic. This particular kid was more on the hypotonic side. They were flaccid. There's a thing called Baton's criteria, which teaches flexibility both in the thumbs, if they hyperextend both knees, if they're plantar, so if both feet are plantar flexed or flat-footed, hyperextended knees, hyperextended elbows, and they can actually bring their thumb to their forearm. That tells us that's a different kind of athlete. That's an athlete that needs to be stimulated in mid-stance and in mid-joint position and have a lot of afferent loading to create more stability. You know?
Okay, we will do one more before we wrap up. Do you feel like teams and athletes as a whole group will need to integrate this work upon return from this current sport and activity shutdown to help prevent the overuse injuries we were sure to see once sports resume?
I think that question hits on the biggest fear of our sports medicine team here. And I think, from our lead athletic trainers to our physicians, we kind of feel that, once the reins come off and they give us the keys to the car, our coaches and strength coaches know they're not going to know any other way to do it except put it in fifth gear and put the hammer down. You have to have control and you have to actually tell and have that conversation where we have to transition these players back to full activity. I think doing these types of things are going to help us where we actually have breaks in the training where we do these things to re-implement or reactivate the nervous system and to make sure that we don't lose anything. I also like training in different environments. I mean, I would highly recommend that we have team days in the pool, that especially athletes that are not pool based, So our football team, our baseball team, get them in an environment that they don't know, and do minimal to moderate activities to kind of wake their system up and prepare them for the load that's going to happen. But I mean, I think that in my mind, that's the best way to do it. The other thing to keep in mind is that if you do neural system activation and stimulation, the athlete's strength comes back faster, and also with less injury. So I think a mistake would be to walk them in the weight room and see how fast we can get to a 1 rep max. I think a mistake would be to walk them on the field and see how quick I can implement a full practice. I think you have to have a graded progression. If you don't take the time to grade that progression early on, you will lose athletes before the season, and you will lose them to major injuries. So it's kind of like, you can pay me now or pay me later. I don't really care, but I would prefer, let's take some time to kind of feed forward a little bit before we get into a situation where we lose something down the road, especially a group of athletes that we need during the season. But that may be the differentiating factor from a successful season this coming year. Whoever takes their time and really progresses their athletes the right way will be the one standing at the end.
All right. Thank you very much, Andre. Just as the Director of Education who's in charge of the accreditation, I would be remiss if I did not mention that Andre did complete a disclosure survey. He has nothing to disclose, and he has no actual potential conflicts of interest and no financial relationships to this program. So I got to sneak that in. But we do thank Andre for being here. So in terms of credit and the course assessment and evaluation, that will be mailed out to everyone at the email address that was used for registration. So you will see that in the upcoming days in your inbox. That will come from the Center for Sport and _Education at Tulane.edu. If you have any questions or do not receive that, please feel free to reach out to me at that email address. We do have an upcoming webinar that's going to be on May 13th. We will have Kate Hollowell will be joining us from Wichita State. So please tune in for that, and promotional flyer will be sent out later as we get closer to that event. Please do allow for about a 24-hour to 48-hour turnaround for your certificate. At any time, if you feel like you're not receiving anything, just feel free to reach out to me at that time. And we thank you for joining us.